Friday, Baylor College of Medicine and Friends of Baylor. So my sister wants to know, when are we doing a Q&A? So Janet, we're doing it today. Now here's the thing. I've gotten more questions about what do I do about my vaccination, my booster, should I get a second booster? There's absolutely no clear indication yet what to do by the FDA and CDC. They're kind of moving towards recommending a second booster. But the fact is that it's very confusing. So I'm going to have to show some data in the beginning just to sort of explain the setting, and then I'll answer a lot of the questions. And it also has some personal thing, because I got COVID again. Anyway, so I've been saying the last couple of weeks, notice that the case numbers are going down and that the hospitalizations are going down. But the piece of information that doesn't make sense with all that is if you look at wastewater analysis, 40% of the wastewater sites in the United States are reporting not only an increase, but large increase. So there's a lot of virus around in wastewater, and yet we're not seeing the number of cases. So you could argue, well, one of the issues is that most people are not reporting cases anymore. Well, why not hospitalizations being a surrogate marker? Well, probably because the virus has changed to the point where it's not as severe and we're seeing fewer hospitalizations. So what indications do we have? Well, we don't have a lot of good indications. But let me tell you my own experience so that I can help guide your own. So, like many of you, remember the pandemic began in December 2019. As soon as a vaccine was available, I got my first dose, and then I got my second dose. I couldn't, my second dose, like about 8 months later, I got the first booster. But remember, the booster was to the original Wuhan spike protein. And then, because it had been 5 or 6 months later, and I'm a nervous guy, I got a second booster, only this time with the Moderna. Again, but all of these to the original Wuhan antigen. Then, last summer, July 4th, despite all that, I got my first infection with COVID. Now, if you go back to look at what was the dominant strain back then, that was the Omicron strain BA.4/5. So Omicron appeared. And what was very clear back then in July and the winter before with the big peak spike in Omicron, that the Wuhan antigen and your immune resistance, your immune response to that was not protective against the BA.4/5 Omicron variants. So, I got sick, but what the heck, I was just before I wanted to get a bivalent booster, but I got sick beforehand. But I waited. And because I recommended to people, even if you've been infected, get a booster, I went ahead and got a booster. So I got a booster in October. And then, I've been sitting around like many of you going like, well, when should I get my next booster? When should I get my next booster? Well, the problem is that what's happened now is the dominant strain is that XBB strain that I told you about. And so, lo and behold, 10 days ago, I got the XBB1. I'm sure XBB1 because 92% of the variants are XBB1. So like I recommend everybody, and this is important when you think about what to do, I felt kind of ill, and I didn't want to infect everybody. I was at a meeting, so I tested myself, and I was negative. And then I developed symptoms, and I was very positive, and I remained positive for the next 6 days. It took 6 days to clear the virus. Luckily, a friend of mine was with me and got me Paxlovid because I was feeling pretty bad. And when she went to the pharmacist, she talked to the pharmacist, and the pharmacist said, well, there's a lot of virus around. I've been prescribing a lot of Paxlovid. But that is completely inconsistent with what we're reporting. So what does that mean? Well, it may well mean that if we could follow the number of prescriptions, we'd have a better understanding of how much virus is actually out there. So I just want to show you the lineages and why this is important. These kind of lineage maps, the distance between the various lineages represents the genetic diversity, how genetically different they are. So this was the original Wuhan strain. Omicron sort of started with this group, and this was the BA.4/5, so the one that I got infected with, pretty far distant from the original strain, which is why you had very little immune protection. XBB1 is almost equidistant, so you can see that there's very little protection from BA.4/5 with XBB1, which is why I now got that one. So what I did was I did exactly what the pharmacist had said, and I found out how many Paxlovid prescriptions were actually ordered last week. So last week, the CDC reported 139,000 cases of COVID. But also last week, when you go to the number from Health and Human Services, there were over 160,000 Paxlovid prescriptions written. So we know there were more Paxlovid prescriptions written than there were people reported who had the disease. And we also know that the only people who get Paxlovid are those who should be over the age of 50 or 55. And you know not every single one of the people who got infected over the age of 50 got a prescription. So I looked up what percentage of the cases last week that were reported were actually over the age of 50, and it was 45%. So if you just do the math, at least 350,000 people were infected last week, even though the number was reported was much less than that. So I think we have a vast underestimate of the amount of virus that's out there. And everybody who's got a cold should be probably testing to see whether or not it's COVID, because there's no flu around anymore. RSV is not around. So my guess is most of the coughing, sniffles, and everything is probably COVID, and people need to probably test. So now getting to the Q&A. And this is relevant because I really have changed my recommendations based on all this data. So one of the viewers wrote, I had my primary series, Pfizer, and the booster 8 months later, and my bivalent in October. When should I get my next booster? This is the question I get asked all the time. Well, I can tell you right now, to maximize your immunity to those strains, your immunity only lasts about 6 months. So normally I would say, well, wait till, so it's October 22. It's now 4 or 6 months later. In spring, normally I'd say wait until the fall. But in fact, there's so much virus around right now. And we do know that being vaccinated protects against serious disease and death and hospitalization. So even though you may get infected, it's worth being vaccinated. So I would go ahead and now get the updated booster, the bivalent booster again, and then I'd wait and see in the fall if they finally come out with one that's to the XBB version, I get that one too. Right now, the current recommendations, the FDA right now has not recommended a second booster yet, although we think that's going to come out soon. We think that the FDA and the CDC will recommend shortly that for over the age of 50, people will be recommended to get a second booster. But I would go ahead and get it. Now, the most important thing is, I've said this the last almost a month and a half, XBB is the dominant variant, and that's very good. As long as it stays XBB, I think we'll all have a chance to either get it or eventually be vaccinated against it, but there won't be we hope there's not a new variant, although there's one on the horizon. What should I do if I'm traveling abroad this summer? I'm planning on traveling abroad this morning. So I think all you can do is right now the only vaccines that are available are to the original Wuhan strain and to the Omicron BA.4/5. That's the bivalent strain. Dominant strain out there is XBB. So be up to date on your vaccines, because being as immune protected as you can be will help even if you do get infected with XBB. But I would say it's not going to be protective, so it's not going to be protective from getting infected if you're exposed to it. So I would take several test kits with you so you can test to see whether or not you are positive. And I'd also take a course of Paxlovid for everybody who's over the age of 50. So if you're traveling around and you start getting sick, you can test yourself. Remember, you have to test twice. Just like when I did the first one, it was negative. The second one was positive after I became symptomatic. And hope for the best. I mean, right now we do not have a vaccine that is totally protective for XBB. So the only good news is that it has been very effective against serious hospitalizations, and we see that. There haven't been a big spike in hospitalizations, and it has been protective against mortality. There's been one new paper out, we reviewed it last week, which is if you're slightly obese, BMI over 30, you should have a discussion with your physician, because there was the one paper that showed that metformin co-treatment was actually beneficial in reducing hospitalization. So you might be a person that would be eligible for a course of metformin while you're infected, but again, that's something you should discuss with your physician. Okay, another question. Earlier this week, the WHO announced that persons in high-risk groups that should get COVID boosters every 6 to 12 months. I'm 80, I'm in a high-risk group, I've been fully vaccinated and boosted. Should I get another Omicron bivalent booster? As I said, this is the thing I always hear. Or should I wait until the fall when an XBB booster may be available? Well, I would get the bivalent booster, second booster, if it's more than 6 months since your last one, and hopefully there will be an XBB vaccine in the fall. Okay, then there's the question, what is the latest with Paxlovid? Should you start taking as soon as you get a positive COVID test? Does it help with long COVID? Absolutely. You should take it the minute you know you're positive, which is why you should test, and especially over the age of 50 or immunocompromised. And there's a large group, we reviewed this paper a few weeks ago, large study in the VA that showed that Paxlovid lowered a chance of getting all-cause of long COVID and reduced the chance of getting 10 of the 13 symptoms that were associated with long COVID. So yes, there's good data to support that Paxlovid helps reduce it. Another question, I read that most COVID deaths occur in people over 65. What can we do to protect nursing home residents? Well, that's a really good question. There was a new study in the New England Journal that came out that looked specifically at nursing homes and conducted surveillance of the staff members who were taking care of those patients. And what they showed was that you can detect people, and it was actually beneficial because you can identify people who might be carrying or be asymptomatic. And so surveillance is the best way to go. Here's a good one. COVID talking. Often I have friends that say they have the sniffles, is it cold, allergies, flu, or COVID. Does it really matter? Well, it does matter because we have a treatment strategy for COVID. They share a lot of the symptoms in general. If you have fever and a headache or you're in bed, that's usually associated with RSV, flu, or COVID. Right now, RSV is not around, flu's not around. So if you really are severely ill like that, it's most likely COVID. And you definitely should test because, for one thing, you can treat, and for the other reason is you don't want to infect everybody else. The best way to find out is get a COVID test. They're very easy, very reliable to do at home. And I just remind everybody, if you get a negative one, don't assume you're negative. Get a second one the next day. Can you give me an update on the myocarditis? Seems like there's been an increase in cardiac deaths in young people. So that's a really good question. We talked about this a couple of weeks ago. There has been an increase in acute myocardial disease in young people. There's been a lot of experience now with the mRNA vaccines. There has been this myocarditis and pericarditis associated with the vaccines, 50 in a million doses. It's most often after the second dose, usually within a week of vaccination, and there's been no increase in mortality associated with that. In contrast, there has been a much bigger increase in association with COVID. So it's much worse to have COVID because it does have a significant association with cardiovascular disease risk, and we reviewed that last week. There was a study by Eric Topol's group, or Eric Topol reviewed a bunch of studies, 6 studies, and what he found was that the risk of heart attack or stroke beyond 1 month after COVID was about 2 to 5-fold increase over people who did not have COVID. And he also found some studies that showed that vaccination reduced that risk in half. One viewer wrote, did AstraZeneca's COVID vaccine have end up having a higher heart risk for young women? And there was a study that just came out reviewing the older experience in Europe. And you remember that vaccine was restricted sort of in 2021 because of safety concerns. But they did a long-term trial, and it turns out there was a significant incidence. And remember, that's not an mRNA vaccine. That's a sort of traditional vaccine with an adenovirus vector. But it showed that there was a pretty significant increase in cardiovascular risk after that vaccination. So that was one of the reasons why it was discontinued in Europe. One person wrote, as I agree that wastewater analysis is the best way to monitor, but with 15,000 or more waste treatment plants in the U.S. with such a giant system, how do you ever fund that all at once? And the writer goes on to say the key would be, and here I'm just editorializing, to create a pilot program so plants would have something to join. And that's a really good comment. We agree. He's 100% right. That is the best way to monitor now in the United States. We think that's what the CDC should be doing. We started a program here with Rice and the city of Houston, and we have a great program that looks at wastewater surveillance. And I've asked our own institution to figure out, and our scientists to figure out ways we might collaborate with other municipalities. So very good idea, and I think that is something the CDC should do. Okay, this is the one that a viewer wrote in. A new COVID Omicron variant seems to be increasing in India. What can you tell us about this? And yeah, as long as the virus is replicating anywhere, there'll be variants. This one is called the XBB 1.16. The one that's circulating now is 1.15. So it's closely related. It is replacing the viruses in India, so it's probably slightly more infectious. India recorded a big jump. You remember I've been showing you India looked pretty good. Well, they had a big increase in case number, almost 3,800 in one day. And the sequence in it was XBB 1.16. So far, it's in the United States, but there's no real evidence that it's worse. My guess is if you've been infected with the 1.5 or 1.15, it'll be cross-protective against the 1.16. So small variations like that are probably not going to be a problem. I'm sure that the vaccinations we've had against the Wuhan original strain and then the Omicron strain are not going to be protective against either one of the new circulating XBBs. But if you've been infected with XBB like me, you're probably protected from this one. This is one that somebody read, like scientists are expressing fears that COVID could combine with a much more lethal coronavirus like MERS. And this was a theoretical paper that was written. You could, in theory, have SARS and MERS caught by the same person and have a recombination event. That's pretty unlikely. The way that the virus gets into cells is different, so it's unlikely the viruses would end up in the same cell. But recombinant events are the things that I worry most about, and if you'll recall, this chain of the Omicron variant was a recombination event between BA2 and BA4 that led to the big Omicron surge. So it is likely, these variants can occur, recombination can occur between these Omicron-related variants because they both get into the same receptor in the cell. So two viruses could be in the same cell. That's what we worry about most of all. The original Omicron was probably in South Africa, and a patient who's immune compromised got the opportunity to have many viral strains that were not eliminated and probably had some recombination events that led to that dramatic difference from the original one. We had one physician that said, well, what about this new fungus? It's not bad enough we got coronaviruses. So there is a new Candida auris that has been reported in the United States. And it's been particularly growing in immunocompromised hosts. The big concern is this slide here. You can see this is actual infected people in dark blue, but light blue is that it seems to be colonizing. So when you screen people and just look on their skin or stuff, it seems to be increasing, and it's particularly resistant to antibiotics. So this is a concern. It's in the United States, in the West Coast, in Florida and Texas, some of the Midwest, and as we've talked about over the years, resistant fungi and bacteria are going to be a real problem besides the viruses, and it's something we need to be studying all the time. So this Candida auris is in the United States, is colonizing a bunch of folks, and it's a problem. So I want to end today with a bunch of shout-outs. First of all, this week we were honored to have Congressman Al Green visit Baylor and announce a $7.1 million congressional grant to Baylor College of Medicine and the Children's Nutrition Research Center as part of the FY23 Community Project Funding Program. Now, when you get a check that big, sometimes it actually is physically large. I've been looking for an ATM to deposit this, and if you'll simply call me and tell me when you get one, I'll put it in. Anyway, also want to congratulate our middle schools. Our middle school students at the Baylor College of Medicine Biotech Academy at Rusk and the Baylor College of Medicine Academy at Ryan belong to Health Occupation Students of America Club. And 56 Rusk students competed in the Texas HOSA State Leadership Conference, and 39 of the students won awards at the conference. The team collectively earned 29 awards. In addition, 33 students qualified for the International Leadership Conference. Big shout out to Mrs. Lisa Schneider, the Health and Physical Education teacher, was named State Advisor of the Year for the second time. 10 students from Ryan also competed and did well, with 6 students receiving awards. Rusk students, Ramatuli Lopi and Lucille Lopez, competed in the Texas Science and Engineering Fair. Ramatuli advanced to the blue ribbon judging round and placed first in her category of behavioral and social sciences. So congratulations to you. I can't wait. I'm visiting both schools next month. And finally, this week marked the beginning of Passover, which ends on April 13th. Happy Passover to all of those celebrating this week. Easter is this Sunday, and Lily will be looking for a basket filled with dog treats, as she does all the time. Anyway, I want to wish everybody a happy Easter and a great holiday season, and I can't wait to see you next week.